Morning, everyone. I have the good fortune of starting you off. It's pretty. Oh, yep, here it is. He needs his mobile device. Of getting us started this morning after what I'm sure has been a really interesting week of really good conversations. It looks like you all have had a lot of rich discussions around everything from, doing sort of statistical analysis and sort of these health interventions to taking some of the latest and greatest and putting it into healthcare settings. As Dr. Shetty mentioned, I'm going to take us to a more sort of tactical place, I think, this morning. And really hopefully get you all sort of thinking and also invite you all to share your own experiences around some of the challenges with deploying some of this stuff in some of the most resource scarce settings around the world. So with that, let me flip this thing around here. I always love it when I give presentations at technology forums and have problems with technology. Okay, there we go. So before I really kind of dig in, I just want to give you a little bit of context as to where I'm coming from so you sort of understand the perspective a little bit. So I work for Qualcomm. I work in our wireless reach initiative. For those who might not be as familiar with Qualcomm, we were founded about 30 years ago. And our core competency is really around creating and innovating around advanced wireless communications technologies. So our business model is very much focused on doing sort of really heavy investments in R&D, then sort of licensing those inventions really broadly out into the mobile ecosystem, capturing revenue, and then reinvesting that back into R&D. We're probably most well known for some of our chipsets that power a lot of mobile devices. I like to sort of say for non-technical people, sort of 3G is one of it's sort of our sweet spot in the mobile ecosystem. So what you're looking at here is actually some of our data around our wireless reach initiative, which was founded in 2006 with really the key objective of using Qualcomm core technologies to improve the lives of underserved communities around the world. We actually work in lots of different business verticals, not just health. And really what we're trying to do is create sort of these demonstration programs that we design by their nature to sustain and scale that use Qualcomm core technologies in the areas of health, education, entrepreneurship, public safety, environment, sort of important areas. Here you can see we're at over 100 different programs in 40 different countries in various stages of development. We have worked with or are working with about over 450 stakeholders, and what that means is we use a public-private partnership model in how we do our deployments. So we work with private sector, nonprofit, government, academic partners to really deploy these programs. And we're at about 7.8 million direct or indirect beneficiaries in sort of our touch point. So the structure of my talk today, I thought I would start by just sort of saying out of that 100 plus set of programs, about a third of those are mHealth deployments. And we've been sort of doing this mHealth intervention since 2006, like I mentioned, sort of like the early days a little bit in terms of using mobile broadband-based solutions in mHealth. And so over the course of all of those different activities, we sort of synthesized up a couple of key things that kind of pop for us in terms of things that we try to do to help reduce barriers to scale, especially when we're looking at large-scale mHealth interventions in really resource-scarce settings. My slide doesn't look very nice. I apologize. It looked nice on my computer earlier. Basically, what we're trying to do within wireless reach is look at how we can use mobile broadband-based tools as sort of the backbone of some of these health system strengthening activities. And so what we've done is really looked at, okay, what kind of sort of key focus areas should we be looking at where mobile broadband makes the most sense in terms of a monitoring tool, where we can have sort of large impacts. And we've kind of taken that to kind of zero in on a couple of key areas. Chronic disease management probably gets mentioned a lot at these kinds of conferences, and that's for good reason. So we look at chronic diseases, both communicable and non-communicable diseases, child and maternal health, aging in place, and then I think what's becoming more and more clear to folks that are practitioners in the area is that we need to empower frontline health workers around the world with good job support tools, good professional development, and mobile can be the way to reach those folks. In terms of reducing barriers to scale, all of our programs really sort of have these areas underpinning them. So we're really always looking at how can we, productize our interventions, right? So how do you figure out the financial sustainability model? And the big question of who pays is really pervasive in this space. A lot of people think, I work with a lot of different kinds of folks who are really brilliant, and the ideas sometimes are just so compelling in the technology, and a lot of folks kind of think it's just so compelling, so why wouldn't people use it at scale? And usually it's a little more complicated. There's a lot more context to it than that. Building the evidence base, I'm sure all of you have had lots of discussions about how do we analyze impacts to these interventions so that we can justify health outcome improvement, cost reductions. Engaging with local and national ministries of health cannot be it is probably the most critical thing, actually, when you're talking about doing these sort of deployments. And interoperability is also really important. We'll go through a couple different case studies where we'll go into this a little bit more, but you want to use stuff that's really sort of commercially available, off the shelf, to the extent that you can, and then add value-added services on top of that, because really interoperability is where you're going to get to the place where you're going to have sort of that tipping point into scale. So let's go ahead and start talking about some of these things from a tactical perspective and get into some of these global case studies that I mentioned. I thought that I would start with a program that we have in Nigeria. So this program's really, it's kind of simple on the face of it, right? Basically what we're doing in Nigeria is working with a number of private and nonprofit and government entities to deploy a tablet-based solution that allows midwives and essentially frontline health workers access to a fairly simple open source-based electronic health record with some decision support underneath it, right? So you can imagine someone presenting to a midwife, or a midwife is out in the community and needs to do an exam, there are actually pre-built sort of forms that will guide the midwife through the right kinds of questions to get a complete, accurate exam. For folks who might not know this, most of the world is getting their health care from a frontline health worker. And typically frontline health workers, they have anywhere from about a high school to maybe a couple of years of technical education after high school. And they're way out in the fields. They don't tend to have a whole lot of supervisory support. They don't tend to have a lot of opportunity for professional development. So what we're really excited about is if every frontline health worker had, one of these in their hands, they could easily get in touch with their supervisor or kind of be participating in ongoing training. So this is, again, fairly simple kind of solution on its face, right? Where these things get kind of challenging is we have to think about, okay, this is really, really remote areas. This is an electronic health record where everything has really been fairly paper-based till now. And what we sort of saw is that by collaborating really, really closely with the National Primary Healthcare Development Agency, we were able to actually design into the EHR their requirements from a government perspective. And as a partner at the table, they're learning about how to kind of deploy these and are actually modeling some of their national EHR or electronic health record off of off of this deployment. So the pilot initially rolled out in 14 clinics in 2013, and you can kind of see we're able to expand pretty quickly within a year to about 51 clinics to give you a sense of the uptake. And geographically, Nigeria only has 6 states, so I mean we're in 4. The coverage of this kind of program has really taken off, which has been really great. And I think that has to do with a lot of different things, but usability, sort of ease of use of the technology, those are all things that are really important. One thing I just kind of want to underscore about this program, one of our partners from Vecna Cares actually uses this analogy a lot, and I think it's a good one. If you build the road the right way, any kind of car can drive on it, right? SUV, hybrid, whatever, doesn't matter, right? So what we're talking about doing here is let's build the health systems, the infrastructure the right way so that people can innovate and add value-added services on top of it forever, right? So, really looking at, okay, we've already got this mobile network that's built out and fairly robust. Let's build on top of that. And so that's really what's happened here. And I think a great example for this is that this was a program that was built for child and maternal health, right? And then all of a sudden Ebola crisis hit. And we had all these frontline health workers who just didn't know what to do. They didn't, we just didn't know what to do to help them. And our folks on the ground were like, we already have this infrastructure in place. Let's do a quick survey to understand what our health workers know and don't know about Ebola, then push out individualized learning modules through our solution, and then do a post-test to see, okay, how much did they learn? Is it really helping them in their daily practice? And they were able to do this incredibly fast. I actually was even surprised by it myself. I think they were able to push out the initial survey within a week, and they were able to roll it for a couple of weeks, get data back, and then push out the training very, very quickly. So we're talking like weeks to get very, very geographically disparate folks educated. And some of just high level stuff. I mean, I think for every one person that took the training, they were able to educate about 4 other people on some of the realities around Ebola, and really helping folks identify potential patients that could have been presenting with Ebola and how to kind of manage those patients and get those patients referred and managed properly. So I think it's a really great example of how something can be very quickly and rapidly adapted out in the field once you have the sort of infrastructure in place. Feel free to interrupt me, by the way, if you have questions. So I'll just kind of speak to this one because I think, and this is actually, this program in the Philippines is one of our longest standing programs and almost wins the award for largest number of public and private partners. This started back in 2009 as sort of a loose coalition of folks. USAID was involved, RTI International, which is a nonprofit organization. Smart Communications was the operator partner. Just a lot of folks at the table. And basically the idea was, let's create a mobile-based open source software EHR that could be community driven and basically could work off of a dongle, like a laptop with a 3G enabled dongle. It could work off of a smartphone. It could work off of a tablet. And basically the idea was, let's put this in the hands of the rural health clinics, very similar kind of concept as the Nigeria program, and kind of get it out there. And what we found, and the reason I show this one is because I want to sort of talk a little bit about sustainability, because people talk about scale, and you can get scale in some ways very, very quickly depending on your definition, right? Like, I mean, you can push out an app on Google Play and it's suddenly available to, whoever has an Android phone. But sustainability is actually a different kind of thing to think about. And in this case, we had this group, lots of different public-private sector partners. They were able to catalyze this really great idea up and running. We had this pilot roll out in 4 clinics and 4 municipalities in 2010, which then expanded 100 different clinics and 24 different provinces, massive kind of scale. But then the partners were sort of like, okay, well, how do we support this thing? Even open source software needs support, right? There's going to be bugs. There's going to be software enhancements. How do we support training for people that are using this on the ground? And so basically, all the partners came together and said, we think the right mechanism for this is to create an NGO, its own standalone NGO that could manage and be a service provider for this electronic health record service in the Philippines. And so 2 years ago, the Wireless Access for Health NGO was born. And basically that sort of reframing of the institutional support structures for the program has been able to support the ongoing deployments of this EHR. And what's really great is because in some ways the partners were sort of first movers in a sense for this EHR deployment. They've been able to develop a very, very good working relationship with the Philippine health insurance, PhilHealth, which is the national healthcare provider in the Philippines, as well as the Department of Health, and are really working very much in the nuts and bolts of how different EHR service providers are able to tie into the health exchange in the Philippines, which is going to be rolled out in the next couple of months. So I think that this is just a really, really good example of not just scale, but thinking about sustainability and revenue streams and what the institutional structures around a deployment need to look like to kind of support some of that. So I'm gonna, this is actually my last kind of case study, and I raise it because it is in the United States. And sometimes we forget that we have extremely resource scarce settings here in the United States. And I also like this program because it started way back in 2010, catalyzed by the Office of Public-Private Partnerships through the NIH, which is I think kind of a nice tie-in to the conference this week. And basically, I think there's a lot of lessons learned in this program, but one of them is that sometimes it takes a really long time to get the right mix of partners at the table and to figure out how to best work together. And we actually started this in 2010, but we didn't actually enroll our first patient until the end of 2011. So it took a very long time to kind of get everybody together and sort of figure out, okay, what is it that we're going to do and how's this all going to look? And basically the idea was to do a very kind of simple thing, we thought, right? We were going to do basically a feasibility study just to see if we could do some remote monitoring with patients with congestive heart failure in northern Arizona. And the idea was, let's see if we can do some remote monitoring and reduce the 30-day readmission rate, which at the time and still today is really important. Hospitals are responsible for their patients from the moment they're discharged up to that 30-day window and beyond, really. And so we kind of put together this idea. We were going to use a smartphone. We were going to use peripheral biometric sensors. So we're going to use a SpO2 meter, weight scale, blood pressure cuff. And this is back again into 2011. This was kind of new stuff. Bluetooth stacks weren't talking to each other. Stuff kept coming unpaired. And then we were like, okay, well, we're just gonna try it and see how it goes, right? And so we started enrolling patients, and we found out, these patients live in ultra rural settings, no electricity, no plumbing sometimes, no roads sometimes, 2 hours one way to the hospital sometimes, and these are congestive heart failure patients that kind of need that interaction almost day to day. So we said, okay, how about we throw a solar charger in there with the backpack? And we even went through probably like 4 different iterations of what we'd actually send the kits out in. We had them first in these like hard plastic cases that were impossible to open. And then we had them in these like, camera bags, but then those were getting thrown into the back of trucks and knocked around. And so, just kind of things to think about, right? When you're doing these kinds of deployments. And then, interestingly, we started getting back some really, really good anecdotal stories. We were hearing that patients were doing a lot better. Their care providers, like their daughters and main people in the household that were taking care of some of the patients were feeling like their relatives were doing a lot better. And we thought, oh, we didn't really set this up as an outcome study. We didn't really set this up as a trial to look at this from an outcomes perspective. But luckily, we had some really good dedicated partners, especially through the NIH. And some of you may know Bill Riley. He was at in the National Blood and Lung Institute back then. He's at NCI now. But he said, let me just look at the data. Let me see if I can kind of parse out some outcomes data. We'll look at match control comparisons and some different kinds of ways of looking at the data. And you can kind of see here in the results section, once he was able to kind of get in there and look at it, we found pretty remarkable pre and post results for folks that were enrolled. Patients were not being hospitalized as frequently. When they weren't staying as long because they weren't as sick. And then cost savings were pretty darn significant, to the point where Flagstaff Medical Center out of Northern Arizona Health said, we have to keep doing this. This is just going to be something we need to figure out moving forward. And so I think this is a really good example of how you just got to be super adaptable and kind of working at it every week. And even your research needs to be kind of agile, right? Because you're going to be tweaking your intervention along the way, which means you can't have this all the time. Sometimes you can, but you can't have this like very clear, beautiful clinical protocol that's not going to change if you're kind of adapting on the fly. The other thing about this that I think is a nice takeaway is just that think about where you're deploying your solution, right? If there's no electrical grid, you need to think about that. If the coverage is somewhat there but kind of pocketed, I mean, in this case, we had to come up with caching for the data so that it could be time-stamped properly. We had to come up with literally a map so that the care coordinators in the hospital could tell patients where to go drop their data. Drive to the grocery store down the road to drop your data because your house doesn't necessarily have the coverage. So it just kind of, these sorts of things are really important to think about when you're putting these programs together. And I mean, the good news is Flagstaff Medical Center has taken this program, they've run with it. We're even in conversations with looking at doing some expansion, and actually there'll be some news on this next week. So if you're interested in this program, just take a look kind of early next week. There should be some news on this one. And so just really quickly, the photo on the left, these are our actual patients. In Northern Arizona, there's a very large Navajo reservation, and this is Woody and his daughter Rita. And Woody didn't speak English. He was taken care of by Rita, and they found this program to be extraordinarily helpful in terms of quality of life and feeling really cared for by the hospital. So circling back in my last sort of couple minutes here, these are high-level takeaways, but I would just say that everybody in the room has their own experiences, and really the only way we're going to figure out some of these really intractable challenges in terms of deploying these things is to talk to each other, so that every time we're going out to do a new mHealth intervention or we're trying to solve a challenge, we're not reinventing the wheel every single time. And there's some really, really simple things that work really, really well. Getting on the phone and talking through these things on a regular basis is probably, for me, it's one of the most important things. So yeah, with that, I'll just kind of say thank you for letting me come and sort of share some of my experiences, and would really love to hear from you all if there are any questions or anecdotes too.